Hello, and welcome to a really exciting video session that we are going to do today. My name is Carrie Baker, and I am lucky enough to serve as the president and CEO of Health Impact Ohio. We have been engaged with Metro Health and several partners and stakeholders around the state of Ohio in implementing the Heart Healthy Ohio Quality Improvement Program. And today we're going to have a conversation with our lead facilitator, Caroline Carter, who also serves as the Chief Transformation Officer for HIO, with several practice representatives. Caroline?
Great. Thank you for that introduction, Kerry, and welcome everybody. It's such a pleasure to be here and such a pleasure to have a conversation with you about all the work that you've been doing in the Heart Healthy Ohio initiative. So as Kerry said, I'm Caroline. I'm a quality improvement coach, and I'm designated primarily to help practices through their Heart Healthy initiative. My role is to support the practices in their quality improvement initiatives and to introduce and support the use of the Institution for Healthcare Improvements model, that's IHI model for improvement, which essentially uses small tests of change cycles and PDSAs, Plan, Do, Study, Act. So that's just saying it for those that are not here and are not familiar with it. So for today's conversation, we'd like to share the Heart Healthy Ohio Initiative quality improvement experiences of a few very different types of participating practices. We're excited to be talking to representatives from CVS, the nation's largest walk-in healthcare clinic, and 3 of CVS's minute clinics within the Youngstown area are participating in HHOI. We'll also be hearing from the Metro Health Medical Center, that's Cuyahoga County Safety Net Health System, and we will hear from Physicians Care Connection, a free clinic affiliated with the Columbus Medical Association, located in Columbus, Ohio. So 3 very different healthcare sites in 3 very different regions of the state. So our session today will begin with brief introductions from each of the panel members who will choose to share why they chose to participate in this Agency for Healthcare Research funded quality improvement initiative. Despite the terrible timing, you still chose to participate. You may recall a recent disruption called COVID, where we were trying to recruit practices to participate mid-pandemic. So I'm not sure what that says about everybody, but you participated and said yes to the call. So we'll hear about how your practices decided to focus on your QI efforts to reduce the number of cardiovascular events across the state of Ohio. And we'll wrap up asking each site how they plan to sustain the work. So let's begin with a brief panel member introductions. I'd like you to share your role, which practice or healthcare system you're with, the geographical location of your practice, and the type of the patient population you serve.
Thank you so much, Caroline. My name's Tammy Todd. I am a nurse practitioner with CVS Minute Clinic, and I've been with CVS for 15 years. I am the senior manager of quality, and I support many of the quality projects within this organization. And we were really excited for the opportunity to share our knowledge and experience in applying the Heart Healthy Ohio QI project implementation at CVS Minute Clinic. CVS Minute Clinic is one of the nation's largest retail health clinics with more than 3,000 nurse practitioners and physician assistants and over 1,000 nurses. Minute Clinic offers convenient, high quality, affordable healthcare to millions of Americans across the United States and has a very robust quality structure. So it was really wonderful to weave this into our focused evidence-based practice approach and framework. And it's been wonderful to work in partnership with Autumn Jones. So I'll turn it over to Autumn.
Hi, my name is Autumn Jones. I am a family nurse practitioner working for Minute Clinic in the Boardman, Ohio location. I have been serving as the boots on the ground provider to help facilitate the Heart Healthy Ohio initiative at the clinic level. I have been working directly with my Heart Healthy Ohio project lead and also the NP nurse practitioner providers and the nurses within our participating clinics to help create and implement our Plan, Do, Study, Acts. We have 3 Minute Clinic locations participating in this initiative. All 3 clinics are located within the Youngstown, Ohio area. Our clinics are considered convenient care clinics, and we treat multiple types of acute conditions on an outpatient basis. In our clinics, we can treat patients that are 18 months and older. Recently, within the last few years, our scope of practice has expanded to several chronic care issues, including hypertension. In regards to hypertension, we mostly see middle-aged and older patients. Many times, we are the first contact that a patient's had with the healthcare system for several years. So we find ourselves identifying the hypertension or the elevated blood pressure readings on these patients, and we can treat them and have an impact on their health by educating and encouraging them to return for appropriate follow-up and monitoring.
All right, so we will now turn it over to the Metro Health Group, and we'll start with Jane Barr. Dr. Barr, if you would like to introduce yourself, and then each of you just pass it on to your colleague. So thank you.
Yeah, so my name is Jane Barr. I'm the Associate Program Director for Primary Care at Metro Health Case Western, and also Division Director of General Internal Medicine here at Metro Health and the site champion. For this QI initiative, we enrolled 2 internal medicine primary care practices on main campus here at Metro Health Cleveland, Ohio. The first one is a provider or clinician clinic comprised of physicians and APPs. And the second is the internal medicine resident clinic comprised of internal medicine residents. By choosing faculty and residents at the same site, we felt that this allowed for collaboration of effects, as well as the ability to use the same nursing staff and as well as clinical staff for education and sharing of data. The demographics here on main campus are primarily non-white, uninsured or underinsured patients, with Cuyahoga County mortality rate from cardiovascular disease being significantly higher. It's about 200 per 100,000 as compared to the US overall, which is 165 per 100,000, and is twice the national benchmark of 100 per 100,000. This program is allowing us to have a big effect on reducing cardiovascular disease in our population by addressing high blood pressure and smoking. And I'm going to turn it over to Christina Sanders as our other site champion.
I'm Christina Sanders. I'm one of the nurse practitioners in internal medicine and primary care for Metro Health at our main location in downtown Cleveland. I'm also one of the site champions. I'm primarily focusing on the faculty or the provider side that Jane mentioned.
Hi, I'm Stephanie Jackson. I'm a second-year internal medicine resident at the Metro Health in Cleveland, Ohio. I'm part of the quality improvement project for the resident program. And I'll pass it over to Alex.
And I'm Alex Kotzmeyer. I'm a second-year internal medicine resident at Metro Health Hospital in Cleveland, Ohio. I'm also part of the Heart Healthy Ohio initiative. That's part of our QI project that we took up during our second year of residency.
Thank you so much. Now we're going to pass it over to PCC, and we'll start with EC, and then we'll go to Yemi.
All right, good afternoon. My name is EC Ikiraba Green. I am the president of Physicians Care Connection. We are an affiliate of Columbus Medical Association. We are problem solvers. We help people who are vulnerable in this community access medical care and social resources. We operate 3 service lines. One is our patient-centered medical services. Our second is our healthy pregnancy service line. And our last is our social determinants of health. Within the patient-centered medical service line, we operate a clinic with walls and without. What that means is that we are very blessed to have space in our Columbus Public Health Department, and we operate a weekly clinic there. We also have volunteers who see patients in their offices. By vulnerable, we mean people who are lower income, people who don't have insurance, people who are underinsured, people who may have Medicaid or Medicare but lack access to physicians or other resources. We work with new Americans or immigrants, and we also serve pregnant women. So we really are focused on helping those who are vulnerable and can't access those resources here in our community do so. We wanted to become involved in this project because as a free clinic origin, we were shifting over to patient-centered medical services and looking at that model. We want to be, and we've become a medical home for many of the people in our community who didn't have one. And we were switching to an EMR from paper. And so we have been very interested in improving our quality initiatives, particularly around blood pressure, because many of the people that we see, they struggle and have issues with blood pressure. We have many volunteer physicians and other healthcare providers in the community. And then we hire some staff. One person is our star here, Yemi Akimbola, who is the nurse that has been helping us to implement this program. And I'll switch it over to Yemi.
Hello, my name is Yemi. I'm a nurse coordinator for Physicians Care Connection. As EC said, we've been carrying out this QI project at our clinic. And so my role was to help train people in the way to go ahead and take the blood pressure and how to keep tabs on the information. And we are located here in Columbus, Ohio.
So we've done all the introductions, and we can see that we have a diverse group here. So we will have quite a diverse conversation. So I wanted to just start with a fun question. And I'm going to start with Isi, and then go with Jane, and then go to Tammy. So that's the sequence. So the fun question is, why in the world did you agree to participate in a statewide quality improvement project in the middle of a global pandemic?
Why not? The opportunity presented itself. We are very focused on improving our quality of care. When the pandemic occurred, we were one of the sites that kept our doors open. And with that, we restructured how we provided some services. And so as we're growing as an organization, especially shifting to an organization that would be a medical home for people, it's not typical for free clinics to do that, but free clinics do operate in that manner. We wanted to make sure that we were improving our quality. So we thought what we could glean and learn from a statewide initiative on the things that we could do better so that we could serve the people in our community better.
Yeah, I think this is an exciting opportunity to participate in a way to help and renew the energy around interventions to help lower blood pressure and address smoking cessation. I think quality improvement definitely provides a framework to systematically improve that care, standardizing the processes, improving the outcome for our patients as well as our healthcare system. And particularly for this QI project, it does focus on decreasing cardiovascular disease by addressing smoking and blood pressure that significantly affect our clinic population. I also want to, have Stephanie chime in on terms of an internal resident perspective, if you don't mind, because I think it provides some interesting insight as involving the residents in such an important project.
So we were presented the opportunity to join the HHOI project as part of our second year quality improvement project. I personally have a strong interest in cardiology, so this was directly in line with my field of interest. We found the management of cardiovascular risk factors in our patient population specifically have room for improvement. And so I think working as residents, working with the vulnerable population, this project is important to us and allows us to actually make a difference.
I really also agree to the why not statement. Minute Clinic was one of the care delivery systems that did also remain open and often was sometimes the only entry point for acute care. And as we know with COVID, there were many preventative care gaps that we had the ability to bridge. So when we were approached to join the HHOI project, we came forward with great enthusiasm because we are very committed to continuous quality improvement, implementing the PDSA framework. And what I loved about this particular project was how we could engage with our providers and nurses. And with the leadership of Autumn, we are consistently trying to develop our nursing care team to elevate their leadership and project management and really get them engaged in quality improvement projects. So it was a great opportunity for Minute Clinic to really join arms with this really important project.
I appreciate you all sharing why in the middle of the pandemic you would take this up. We have been very impressed and surprised at the recruitment of practices during a pandemic. We recognize that everybody had to change an awful lot during the pandemic and didn't think, frankly, that there would be the bandwidth to be able to take on a quality improvement project. And so it's been very enlightening to us, and we're really happy about this. We also know that each of you came in with different levels of quality improvement, and some came in with no familiarity with the IHI model for improvement, so using PDSAs. And we've learned over time that they're actually now quite embedded in your processes. So lots of work being done on learning the improvement methodology and implementing. I'm going to move on to, we primarily focused, as was said earlier, on hypertension and smoking cessation. And each of you chose to work on one or the other of those. And I think you've all given your reasons for why you chose on that. So for the sake of time, I'm going to pass on that question. What we've seen across the project is that typically both hypertension and smoking cessation are addressed routinely at all the clinics. So it isn't an either-or proposition. We don't want anyone to think that practices that selected hypertension as their primary focus suddenly stop doing smoking assessments. That just isn't the case. But everybody's given their reasons for why you chose what you chose. I want to move on to sharing one specific improvement that each of you have been working on. And I'm thinking of process and clinical outcomes here. So I'd like to start with Stephanie and Alex. If you, as residents, if you'd like to take a couple of minutes to share some of your smoking cessation changes. So what did you do and how is it helping? How's it working out?
So by using PDSA cycles, we were able to reflect a lot on each of our measures we had implemented. One of the measures we used was smoking cessation cue cards that we created. We placed in all of the patients' rooms in the resident workroom. The cards were explained to the MTAs in order to increase screening rates. However, a lot of the residents and attending physicians had questions about the cards and their use. So in order to improve on this outcome, we had one of our members in our quality improvement project go to each clinic group of residents each week and explain the cards and their use. And that ultimately allowed a lot of the clinicians to understand the use of the cards and have better screening rates and kind of prescriptions for smoking cessation. And I can pass it on to Alex.
Yeah. And then, like, since we were actively screening patients for whether or not they were active smokers, we wanted to create some kind of system to translate that so that whenever providers entered the patient visit, they were aware that, yes, this patient has a positive smoking history as an active smoker. So we actually using our EMR, we created an icon on the patient's chart whenever you open it up to indicate that they do have a positive smoking history. And it easily linked to their smoking history, so the provider could address it further by asking them how much they smoked, if they've thought about quitting, what types of tobacco they've used in the past. We addressed these issues about providers. We found out about these issues about providers not knowing where to find the patient's smoking history in our pre-PDSA survey. So we asked providers, like, what's one of the more difficult things? And that is finding out whether or not a patient actually smokes. And then also on the tail end of it, we implemented what we call a smart set in our EMR for people with active tobacco use. So it's a bundle of orders and referrals for both medications and nicotine replacements that we can prescribe to address smoking cessation, or very quick resources to quit lines, or like meetings that we have for counseling for people with smoking cessation. So it kind of streamlined the whole entire process in our practice.
Nice. Thanks for sharing that. I'm just curious whether you've seen any outcomes, any change that supports what you've done is actually working yet, or are we too early in the process?
Yeah, so looking at the data on the Heart Healthy Ohio dashboard, we do have some preliminary data, especially on the prescriptions, like people who have an active tobacco use history for referral to nicotine replacement or prescription cessation, or referral to counseling resources. We do see a little bit of improvement in our practices with that, but we don't really see that much of improvement in the screening process. I think a lot of that we're kind of trying to troubleshoot that is we've had a lot of turnover in the a lot of our MTAs and our clinical staff that are rooming the patients. Whenever we implemented this, a lot of them have changed over. So I think that we need to go back and actually refresh them on the change that we made to the screening process. And maybe we'll see those numbers increase a little bit more. But we have seen some things on the tail end as far as for the people who are active smokers, who are we referring to counseling resources and also smoking cessation, pharmaceuticals, and nicotine replacement.
Right, thank you. All right, we're going to move to Isi and Yemi from PCC to share what's one specific improvement that you've been working on that you feel has been helpful.
So one of the things that we have seen that is improved is blood pressure taking. One thing that was interesting is when we started this process, we had to sit, AC and I and some other team members had to sit through the appropriate way of taking blood pressure. And when she presented the video, we're like, wait, this is from like 18 something or 19 something. It was pretty old. However, however, we found that the information and the steps in there were very accurate and standardized. So we took that video, first of all, trained staff, and then I went on to train everybody at clinic that does blood pressure. So from the medical, because we're a different clinic, we have medical student coordinators, we have sometimes CHWs that help at clinic, there's another nurse at clinic. So anybody who is doing blood pressure on a patient was giving the instructions and had to watch that video as well of how to appropriately take a blood pressure. So right now, all our blood pressure, when anybody at clinic takes a blood pressure, it's a standardized process. Whether I take it, EC takes it, or medical student coordinator takes it. One thing we have found, EC always joked that we used to be the blood pressure clinic. One thing we had found was that not everybody who came in did have high blood pressure, because we found that the process of having them sit for the 5 minutes, waiting for them to calm down, take the blood pressure, repeat it again, told us that it's not everyone who walks in that has blood pressure. And if your blood pressure is high, it would be high regardless of whether you wait for 5 minutes and an extra minute to be checked or you didn't. So it has changed our process in the sense that we are now very standardized in the way we do the blood pressure at clinic. So regardless of who takes it, and also the fact the amount of EKGs we've done has drastically reduced. We had a policy in place before where if it was 160 over 90 or 160 over 100, we're going to have to take an EKG. At this point, it's not that. So we went from taking probably 10 or 15 EKGs a night to maybe one a night. Sometimes we have no EKGs unless we have cardiology come in. So we have standardized our process. We have removed what we call waste, things that we didn't necessarily need to do. And we are more focused in the way we do things. Easy?
So for me, I think that one change, we could have been done with this because it's been so significant for us, the impact that just taking the appropriate blood pressures has had on our process. As Yemi said, we changed our whole intake process so that we are doing blood pressures correctly. This is important. We have people that can't afford medication, or, we have people that, if it's reading really high, maybe it's difficult to get them to an emergency room to do follow-up care. And so really cleaning this up on our end has also helped us gain some efficiencies. We have a 3-hour or 4-hour time frame where we're seeing a large number of people, and to efficiently get 3 people through the blood pressure process has, like I said, it's changed our whole clinic. It's changed our quality, and it's changed our efficiency. It's changed the way that even our doctors are looking and seeing patients and prescribing medications and so forth for them. So for us, that one PDSA, and Yemi, we did giggle that it was like, it's really old, but it really even in my primary care practice now, I'm like, they're not taking my blood pressure the correct way. So for us to have this change for organization in a clinic as small as we are, quality is important. When people think of free clinics, they don't always necessarily think of quality. So I'm just excited that we were able to have that. And I would also say being able to talk to Caroline on a monthly basis, that was very, very helpful. She helped me understand that PDSA is one process. I was building like 5 processes into one PDSA. That also has been helpful because again, quality is very important when you're working with the disenfranchised patient population and when you have volunteer doctors coming in to provide services.
And one more thing that I would add is the fact that we are also teaching patients now. So when we talk about the PDSA to learn how to do one at a time, one of the things we have learned is to now teach the patients and teach them one at a time. So it's not only staff that is being taught, the patients are being taught so they can also take care of themselves when they're not at clinic, and make sure it's one thing at a time rather than 300 things to juggle.
Nice. Thank you for sharing that. And then we're going to hear from Autumn. Autumn, if you could share with us one specific improvement that your practices have been working on.
So one of our PDSAs was to trial an automatic blood pressure cuff in the clinics to help obtain more accurate blood pressure results. And so this is now something that is being considered on a nationwide rollout to all of the Minute Clinic locations. That is one example that I am actually really excited about. I personally love the automatic blood pressure cuff and think it's going to be a wonderful thing for our clinics to have if it does indeed get rolled out. And then one more example too of a change my organization has made based off of our PDSAs is by requiring all new hires to watch an educational video regarding obtaining accurate blood pressure readings. So this is now a standard part of the new hire orientation process.
All right, so thank you for sharing. We've really appreciated hearing just one thing, and all of you have worked on far more than one thing. At the beginning, as EC alluded to, she had 5 PDSAs wrapped up nicely in one. And of course, we have to stop and think, how will we know what worked? How will we be able to track and measure if we're working on 5 things? And that could lead to potential inefficiencies because now you're doing 5 things because we think we need to do all 5 for it to work. When actually, if we tested them one at a time, we might say, oh, actually, we only need 2 of those 5. So thank you so much for sharing. I'd like to just ask you now, overall, what have been some keys to success so far? So as you think about the whole project that you've worked on, what do you feel has really helped? Now, EC mentioned earlier the coaching really helped, so thank you for that, EC. I'll pay you later. Just kidding. But thinking about the other tools and resources, the dashboard, the quarterly webinars, access to resources on the website, possibly having a coach help, dedicated time and personnel, and any additional resources. So for the whole package, what else has been helpful?
So personally, I have found the monthly coaching to be very helpful. Through these monthly meetings, I have now become familiar and comfortable with creating and implementing various PDSAs to help better our practice. Also, I think the dashboard is very useful. I like tracking how our 3 clinics are doing and comparing the results over time. Then we can encourage the ones that are doing well and also reach out and help evaluate any clinic that is not performing so well.
I do agree as well. Coaching has been very helpful because it's helped direct in the way we're supposed to go. And the resources have been helpful. Resources for us. There was the different webinars that were done to help when it came to medication and titration, and the first step, the second step, and things like that, that we could use and give that information to our volunteer providers in our clinic. I also appreciated the resources sent to Caroline that you sent to us about how to take your blood pressure appropriately. I loved the fact that it was succinct and in picture form and in on one page. That's something that has been wonderful to give to patients. It's not a long drawn out thing they have to read. There's a picture and they have highlighted information. So that's been really helpful too.
So I believe the one thing, there's a couple things. Caroline Carter has been phenomenal in really supporting the work. And, when we first started, we had so many ideas, and her support really helped us to learn how to focus on our PDSA, and really get to the sole purpose of the QI focus. And it really helped us to stay focused in achieving our outcome. Secondly, the resources that were available on the Heart Healthy Ohio website were phenomenal. They just had a lot of guidance in terms of video vignettes, resources. We leveraged many of the patient and provider facing resources and actually had used those as guided education reminders around proper blood pressure management and taking. So just the wealth of knowledge there was very critical to allowing us to achieve success as an organization, as well as evaluate our existing documents and provider and patient facing documents to see where we could augment or optimize those.
Yeah, so I think some keys to our success was one, the monthly meetings, the resources on the website, and then of course having Caroline Carter as our coach was invaluable. The other thing that I think led to our success, and I can't say enough about their input and dedication, was the residents. I feel like we had a fantastic group of residents represented here, as well as a couple other of our residents who really, took initiative and embraced this QI project and made the smoking cessation aspect of this project their own by having, monthly meetings, creating the PDSA worksheets. And I think without them, and having their knowledge of the EMR with the icon and the smart set, I definitely feel like we wouldn't have gone as much ahead as what we have. So I just want to put a shout out to the residents and the rest of the staff to their insight.
I always say QI is a team sport. We need the right team around the table. So thank you. EC, I saw your hand up if you'd like to make a brief comment.
Sure. So I'm a data geek. So the data, and I was the one putting the data in. And so that was helpful for us. When Caroline met with us monthly, we talked about dashboards. And I think where we started with data and where we ended with data was significantly different and better for us. And so I took the feedback on missing data elements and we went back and made corrections. So that was another PDSA to make sure that we were getting information into the system. Again, for us, we're changing from paper to EMR, and we have volunteer doctors, so I cannot make them put information into the EMR for those who don't like to do it. So we've done things like incorporated scribes or medical students, or put a process in place so that for those who are still comfortable using paper, we can get their paper into the actual system. And so that was exciting for us, was to actually improve on the data that we were putting in the system, down to the point where we could see that we were not getting scheduling follow-up hypertension visits quickly enough for people by race and ethnicity. So that's something important for us to get that data into the system. For those data geeks out there, to us, that was something that was awesome as well.
Thanks for sharing that. AC, while you've got the spotlight, we'll keep you there. I would just like to ask, what are your plans? And I know we're not quite finished with the project yet, but it's always never too early to plan for sustainability. So what are your thoughts on how you plan to sustain your progress and even spread and scale?
So thanks for asking that question. We're so excited. We are grown out of our wonderful spot there at the Columbus Public Health Department. We are currently designing what will be the PCC Center for Optimal Health. We're going to move our clinical services into our administrative building and build a clinic that is focused on the whole person. And so will be dealing with the patient, but also the person outside of the patient and addressing their social determinants of health. This is going to be an opportunity that is going to allow us to increase our volunteer force by employing digital health by the means of telehealth and telemedicine. And so we have actually got our foot on the door when it talks about the foundational piece of measurement and data. I can't do anything without any of those things. And so I think this project has really spawned us into a space where we'll be more helpful for people who need it in our community. We're also participating in another national QI project around uh, cardiac health with a roadmap. And so, again, these are just opportunities that are helping us be stronger with measuring the information so that we can have the impact ultimately that we want to have with patients. We want to be comparable to any medical practice. Doesn't just because we're a free clinic doesn't mean that the quality of service that we provide is any less. So we want that same ROI that people see. We want to make sure that we're getting, we're seeing the impacts on HEDIS measurements and so forth that other practices see when they employ these type of QI opportunities.
Great, thank you. And envisioning big things.
Yes, 2024. We hope to break ground in 2024, so we'll see.
Looking forward to it. So we'll go with Christina and then Autumn. So what plans or ideas do you have to sustain the progress and spread and scale?
So we're starting to look at sustainability of our interventions. As with the prompt cards that Stephanie mentioned earlier, we were using that as kind of like a prompt for screening. It kind of went from there where patients were actually seeing them in the exam room and also starting dialogue with the provider. So it became more than just a prompt card for staff to ask the questions, to ask and refer. It also became another way for us to start opening up dialogue with the patients. We actually also had another provider from a different site come for a visit, saw the prompt card and was inquiring about how they can get best practice share that as well. So we are looking and starting that planning process and how we can incorporate that to our other locations. One other aspect that we have come across, and Alex mentioned this, was that we had a lot of our MA, so our like the frontline screeners, leave the practice. So we're trying to find a way to quickly incorporate that process into kind of like a quick learn, like with a tip sheet, like a one-pager tip sheet that'll be incorporated with the onboarding for all the new MAs, obviously, and then those that come in that float in for us to help us out. So they'll just be part of their onboarding and it's into our clinic flow. So we're hoping, that will also be kind of like another way for us to make that process a bit more sustainable and spread from one clinic to the other.
Nice, thank you. I love that you've given thought to this already. Thank you. And last but not least, Autumn.
So at Minute Clinic, we plan to sustain this work by continuing to monitor our hypertension metrics and our smoking cessation metrics. And then also one example of a change my organization has made based off of one of the PDSAs is requiring all new hires to watch an educational video regarding obtaining accurate blood pressure readings. And so this is now a standard part of the new hire orientation process. So that is one way that we are showing that the work will be sustained within our organization. And then another way we are sustaining this work is by potentially rolling out the automatic blood pressure cuffs nationwide to all Minute Clinic locations. We will have this as a focus in 2023 for our organization. And so these examples just show that the changes we have made already to help us obtain accurate blood pressure measurements will be implemented long-term within the organization.
Thank you so much for sharing. And this has been a wonderful experience for us to have the opportunity to do this. It's helping get us a better understanding of what's helpful to you. And getting this immensely valuable feedback will really help future quality improvement initiatives. So it will help us decide, what did we offer that just there wasn't much take, it just didn't add that much value. And we'd hate to take away something that you felt really did add value. So I'm sure future practices will thank you for this. And I realize we're over time slightly, and I apologize. Are there any last comments or thoughts that you'd like to add before we sign off? All right. Well, thank you all for your time and for your willingness to share your experiences and valuable insights. We really appreciate all that you do and all that you contribute. Thank you so much. And I look forward to talking to each of you soon. Have a great rest of your day, everyone.